Hello and welcome to this video lesson on cardiac pharmacology, where we will begin to explore how drugs affect the heart. Now, unlike previous lessons, in this video we're going to spend a lot of time reviewing physiology and very little time with drug chemistry. The heart is an ideal organ to study drugs because we observe a straightforward physiologic process, contraction and relaxation of cardiac muscle. Two variables we will especially consider are the contractile strength or force of muscle contraction, inotropy, and the rate of muscle contraction, chronotropy. Therefore, the key question we are interested in, and the focus of this lesson is, addressing how drugs can alter the rate and strength of heart muscle contraction. We will go into much more detail about the chronotropic effects of drugs when we get to antiarrhythmic agents. We will begin this lesson by considering cardiac muscle cells. Under the microscope, cardiac myocytes are noted to contain alternating bands of light and dark areas that are called striations. The dark and light bands are formed by two important filamentous proteins. Actin is a thin filamentous protein that comprises the light band, and myosin, the thick filamentous protein that forms the dark band. Muscle contraction occurs as these two filamentous proteins slide along each other. Two muscle proteins modulate the contraction-relaxation process. Tropomyosin works by wrapping around actin in a way that inhibits muscle contraction. As tropomyosin is released from actin, myosin is able to bind actin and muscle contraction occurs. Troponin is a complex of three muscle proteins that is bound to tropomyosin. Troponin covers the binding site on actin for myosin, thereby also inhibiting muscle contraction. If there was no tropomyosin and troponin, muscle cells would be in a constant state of contraction. Cardiac drugs cannot directly control actin, myosin, tropomyosin, or troponin. To discover how drugs alter the physiology of heart cells, you must examine the chemical element calcium. As intracellular calcium ion levels increase, cardiac muscle contraction occurs, and as these levels fall, cardiac muscle relaxes. The way this happens is that calcium binds to troponin and causes troponin to change its shape. This in turn causes binding sites on actin to be exposed so that myosin may bind to actin and muscle contraction may occur. As intracellular calcium levels decrease, troponin and tropomyosin are able to bind actin, resulting in cardiac muscle relaxation. All heart drugs affect muscle contraction by mechanisms that involve alterations of intracellular calcium levels. This is a crucial point. You may understand the action of any cardiac drug if you understand how the drug affects intracellular calcium ion concentration. As you should expect, the body normally tightly controls calcium. Calcium levels within the myocyte are 10,000-fold less than extracellular calcium levels. It turns out that the cell is exquisitely sensitive to tiny changes of intracellular calcium. The lipophilic cell membrane is an exceptionally effective ion barrier. The lipid bilayer cell membrane is also an effective electrical insulator and is responsible for maintaining the membrane potential. Now imagine a 9-volt battery. If you connect a voltmeter to the terminals of this battery, the voltage difference between the terminals should read 9 volts. Imagine now taking the voltmeter and measuring the voltage difference between the inside and outside of a heart cell. During resting conditions, you would find that the voltage within the cell is about 90 millivolts less than the voltage outside the cell. When considering membrane potentials, it's important to understand that the membrane potential is determined by ion concentration gradients, the permeability of the cell membrane to ions, and by the activity of sodium-potassium ATPase and calcium transport ion pumps. The takeaway message is that there are powerful concentration and electrical gradients that heavily favor the movement of calcium into heart cells. So if the cell membrane is so effective at keeping calcium out, how then is calcium able to enter and leave heart cells? Calcium enters myocytes through selectively permeable calcium ion channels and is removed from these cells by a molecular pump called the sodium-calcium exchanger that pumps calcium ions out of and sodium ions into cells. Let's examine the calcium channel in more detail. The calcium channel is a protein channel that extends across the cell membrane. There are actually several different types of calcium channels. The type found in heart and vascular smooth muscle is named the L channel. L stands for long-lasting. Perhaps the most important attribute of this channel is that it is voltage gated. In other words, calcium may not always pass through the channel. The electrical charge within the cell determines whether the channel is open or closed. The resting membrane potential is electronegative. During this time, the calcium channel is closed. However, during depolarization, the membrane potential approaches neutrality. The calcium channel then opens, and during depolarization, calcium is able to enter the cell and heart muscle contracts. Under normal conditions, calcium enters the cell once each heartbeat during depolarization. This figure summarizes the cellular actions of calcium. First, note that the sarcoplasmic reticulum, represented in the center of this image, is an organelle that stores and releases calcium. It is similar to the endoplasmic reticulum of other cells. During depolarization, calcium enters the cell through calcium channels. Increasing levels of calcium act on intracellular ryanodine receptors, causing the sarcoplasmic reticulum to release more calcium. This process is known as calcium-induced calcium release. Calcium ions then bind troponin, which allows myosin to bind actin and allows muscle contraction to occur. During repolarization, the sodium-calcium exchanger pumps calcium out of the cell. Consequently, troponin undergoes a conformational change that allows it to once again bind actin, and muscle relaxation occurs. We are now ready to wrap up this lesson. We will conclude by considering what would happen if you either raised or lowered levels of intracellular calcium ion. Hypocalcemia is simply a deficiency of extracellular calcium. If serum calcium levels are low, then less calcium will enter heart cells. As you should expect, symptoms of hypocalcemia include reduced force of cardiac muscle contraction, in some cases even heart failure, and also abnormal heart rate and rhythm. There are a group of drugs known as calcium channel blockers that also reduce intracellular calcium levels. These drugs disrupt the movement of calcium through calcium channels. Calcium channel blockers also have negative inotropic and negative chronotropic effects. Why do you think calcium channel blockers are contraindicated in patients with heart failure? We will explore these calcium channel blockers in much more detail during another lesson. However, in the next lesson, we will continue this discussion of calcium channels, and in particular, we will examine how the effects of beta-adrenergic agonist and cyclic AMP are able to cause more calcium to enter the heart cell, resulting in an increase in the force of muscle contraction. This brings us to the end of this lesson. Please leave questions and comments below. And again, if you found this material helpful, I would appreciate if you give this video a thumbs up or subscribe to this channel. Thank you.